So there are two more bacteria, gram-negative bacteria, that we want to talk about. And so we're still talking about gram-negative bacilli. And so hopefully you can start to appreciate that this group, gram-negative bacilli, encompasses a large variety and diversity of microbes that can cause disease within humans. And we have been focused up to this point on this group called Enterobacteriaceae, but notice that we're switching to what are called non-fermenters. And so these are gram-negative rods as well, but these guys are not going to ferment glucose. And then most of them are oxidase positive. And so those are opposite results that we see for the Enterobacteriaceae members. And so it's those biochemical characteristics that are important in differentiating, do I have a gram-negative bacillus that's a non-fermenter, or does it belong to that Enterobacteriaceae member or Enterobacteriaceae group? So there's a variety of bacteria that are found in this, but the ones in boxes are what we're going to talk about. So Bordetella and Pseudomonas. So that's what we're going to do. So Bordetella is a genus, and there's one organism that we're going to be most focused on. So this is Bordetella pertussis. And so that's the name of the bacteria. Pertussis is also the name of the disease, but it goes by whooping cough as well. And so this is a disease primarily in children, but it can affect other individuals as well. And it's going to be very much driven by the ability to attach in the lungs. So we've talked about those adhesins, those bacterial proteins for attachment, but then a series of toxins that are going to lead to the progression of this disease. And so this this bacteria is spread through droplet transmission, so respiratory droplets. And then those cells lining the respiratory tract are going to be the targets for where they bind and where they can affect the physiology. There's also a unique progression of this disease that we're going to talk about. So it varies a little bit. So if you go back to the infectious disease lecture, we learned there are actually 5 stages of diseases. And so that's typically what we have, the incubation phase. And so we are going to see it progress a little bit differently. And it has a specific and unique clinical manifestation. So that's what we're going to talk about in a little bit. So pertussis has a couple different molecules that serve as adherins. And again, what that allows them to do is to attach to those epithelial cells lining the respiratory tract. And so these are the 2 adherins. So filamentous hemagglutinin and pertussis toxin. I know this says toxin on it. It has multiple functions. It's also down here. There are also 4 exotoxins. So we've defined that exo means exiting or outside, and so think of exotoxins as being secreted by and released from living active bacteria. And so these are 4 toxins. So pertussis toxin, that one's pretty easy to remember since that's the name of the disease. Adenylate cyclase, dermonecrotic, and tracheal cytotoxin. So these middle 2 are the hardest. But the trachea is the site of action. So they each do different things, but we're just going to learn collectively what the end results of all those toxins are. And so as we mentioned, the adherins allow attachment to the respiratory tract cells. The toxins are going to negatively affect those cilia. So if you don't remember, when you look at these cells, they have these finger-like extensions on them, something like that. So and that's a terrible drawing, but those cilia are, you can think of them as brooms that are going to be sweeping. A better picture would be, you have a surface, and there are all these little hairs on the surface. So those are cilia that allow the movement of things kind of up and out of the respiratory tract that you inhale with each breath. So it's trapped in that mucus. You can get the cilia to kind of brush things up and out. So these toxins are ultimately going to paralyze the cilia, and not only that, they are going to negatively affect the physiology of the lungs so that the secretions are not doing what they're supposed to do. And as you might guess, being called whooping cough, it's going to lead to a pretty severe cough that has a unique manifestation that we'll talk about momentarily, but that's why it's called whooping cough. So what this axis is showing, this graph, is how the bacteria number are changing over time. So during the incubation phase, so that's the first one, we see an increase in bacterial number. And then there's a second phase. So this is where it deviates a little bit. It's called the catarrhal phase. And this is where the bacteria number is actually peaking, but you haven't got to the peak of the signs and symptoms yet. So this, if you read, it seems like maybe a cold, maybe, cold/cough, nothing that serious, sneezing, malaise, fever, runny nose. But it's this paroxysmal phase that is going to be the most severe, and where it also is going to exhibit, the patient's going to exhibit the classical whooping cough, which is what we think about when we talk about pertussis. And so notice the bacteria are actually declining here, right? A decrease in number of bacteria. And then you might ask, well, why is that the case? So remember what's triggering the change in the physiology of the gut. It is going to be this accumulation of toxins that are made by the bacteria. So even though the bacteria might be declining due to whether it's antibiotics, whether it is the immune system, whatever the case might be, if the toxins have had a chance to be released and secreted and accumulate, then you can get this characteristic repeating cough. And so if you've ever heard it, it's got a very characteristic sound. I'll play this for you in just a second. But it's a cough so severe that it's very, very difficult for the individuals to breathe. And so they have to take these really quick inhale breaths where they make this whooping sound. And you can cough so much that it leads to exhaustion, low blood oxygen content because you're just not getting enough oxygen, vomiting. Oh, it's already playing. So hopefully you heard some of those whoops in there. The number of cases was diminishing because we had a good vaccine, but we're seeing this start to rise again. And so obviously as a parent, if you were seeing that in your child, you would just be in despair, obviously. Even that not being your child, is tough to hear that without having some concerns. So in terms of diagnosing pertussis, usually that whooping cough is pretty obvious. And so the problem then becomes the treatment. Because of what I mentioned before, antibiotics can kill the bacteria, but it has little to no effect on those toxins that have accumulated. So you really have to just treat the signs and symptoms and then move on from there. So we do have different variations of so there's the P, that's pertussis, so diphtheria, pertussis, and tetanus. And they can change the letters around, but nonetheless, we've seen this change over time. So this is up through 2018. So this is where the first vaccine was initiated, and so you can see a nice, fairly rapid decline as individuals were vaccinated, and then it remained relatively low. So from 200,000 cases a year down to almost zero. But then after 2000 or so, we've started to creep up again. So if we zoom in on the area, you can see the slope is increasing, and then we get spikes every so often. So there's a variety of reasons for this, but one is what's called vaccine hesitancy, or people just choosing not to. But there's a decreasing number of kids that have been fully vaccinated, and so that's a concern. What this is also showing, those are the cilia, so those little hairs, and these are the bacteria using those adherins to actually attach and establish. And so as they release their exotoxins, that's going to negatively affect the physiology of the cilia and these respiratory cells, leading to that accumulation of mucus, and then the coughing fits that progress to what we just heard. So the last group of bacteria, there's one more genus that we're going to talk about. It's called Pseudomonas. There's some other ones here. But Pseudomonas is a growing concern. It's an opportunistic infection. It is found all over the place. So there's that term again, ubiquitous. And it's a growing concern in the hospital as well because of hospital-acquired or healthcare-acquired infections. So we'll talk about Pseudomonas right now. It's rarely found in humans, and so if it does establish itself there, it can be an important opportunistic infection. And so individuals that are at risk, obviously immunocompromised patients, but there's some other individuals, and this is just getting a little more specific. You could kind of put these as immunocompromised in different ways. So if you're on a ventilator, so you have that tube inserted, or you have a tube inserted as a catheter, or you have injuries to the skin, which is an important chemical and physical barrier, or you have just a different lung environment because you're a cystic fibrosis patient. Any of these are at increased risk of colonization of Pseudomonas aeruginosa. And once it gets there, it can result in a variety of diseases, depending upon where it's at. And because of a variety of virulence factors that are shown here, hopefully you remember what these allow the bacteria to do. Fimbriae are those small hairs for attachment. Adhesins are the proteins for attachment. These are the two types of glycocalyx, so either for sticking or for avoiding the immune system. These are all gram-negative bacteria, so endotoxin can be an important virulence factor as well. And then this, some Pseudomonas can make this additional toxin, an exotoxin, that's going to inhibit protein synthesis, and that will effectively kill cells. So if a cell can't make a protein, that's going to be really problematic. So a lot of things that can disrupt the physiology, the normal physiology of a human. And so there's a variety of things that it can lead to. But there's several issues with this. So the good news is most healthy people aren't going to get Pseudomonas infections. But the problem is we have a growing population of people that aren't healthy and are immunocompromised in different ways. And so we're starting to see these infections increase. Being able to diagnose this can be problematic because of the potential for contamination. Because the bacteria are everywhere, you're not sure if you're getting it from a patient sample or you're getting contamination from in the environment. One thing that might be a clue in diagnosing is that this bacteria can often make a bluish-green pigment. And so if there's enough of this bacteria present, you can see this pigmentation that's occurring. So this is a diabetic patient with a foot wound, and you can kind of see the bluish pigment not only in the skin, but kind of leaking out because the bacteria are releasing it, that pigment, and so it can actually color the dressings there. Another bad news about this bacteria is it's really hard to treat because it's so resistant to so many different chemicals. So whether that is antibiotics or different chemical agents that we'd use for disinfection to clean a healthcare facility to try to minimize those healthcare-acquired infections. And so really prevention is going to be important in following guidelines for disinfection and sanitization of the different surfaces or different environments that we're trying to clean. And so studies have been done to show what works best for different bacterial species. And so if you know you're trying to limit this bacteria, you have to make sure you're doing it rigorously enough to achieve effective sanitization.